Welcome, everyone, and thank you for joining us at this very early morning hour for an educational webinar on local control, preemption, and tobacco prevention. We're excited to discuss these important issues with you. And before we begin, I'd like to remind everyone that you can use the chat box to submit questions to myself and to the other presenters. You can submit questions at any time, and we'll have two question and answer sessions where we'll answer as many as possible. The first question and answer session will occur about halfway through the webinar, and the second at the very end. And if we don't get to your question during either Q&A session, we can certainly follow up with you after the webinar. For those of you who haven't worked with us before, ChangeLab Solutions is an Oakland, California-based nonprofit that creates innovative laws and policies to ensure everyday health for all. And that includes whether it's providing access to affordable, healthy food and beverages, creating safe opportunities for physical activity, or ensuring the freedom to enjoy smoke-free air and clean water. And these solutions address all aspects of a just, vital, and thriving community, like food, housing, childcare, schools, transportation, public safety, the environment, and of course, tobacco control. So just to start out, I have to give you the spiel. Why I am a lawyer, I am not your lawyer, and at ChangeLab Solutions, we don't provide legal advice or enter into attorney-client relationships. So the information provided in this webinar is for informational purposes only. I also want to note that ChangeLab Solutions is a nonpartisan, nonprofit organization that educates and informs the public through objective, nonpartisan analysis, study, and research. So the primary purpose of today's webinar and discussion is to address legal and policy options to improve public health, but there is no intent to reflect any view on specific legislation. Before we get into the substance of today's webinar, I want to briefly turn over to Scott Neal, Program Manager for Seattle and King County Public Health Tobacco Prevention Program.
Thank you. Hi, everyone. Good morning. We wanted to thank you, first of all, for taking the time out of your busy day for this, and it is kind of a longer webinar, and to participate today. But before we begin, I'd like to provide you with a little more context for today's webinar. Many of you participated in the development of our collective Washington State Tobacco Prevention and Control Program's 5-year strategic plan that was published in 2016. This plan identified a number of priority areas, one of which was educating around the impacts of preemption and benefits of local tobacco and vapor product policies. The content of today's webinar was developed as a response to our state's strategic plan, and we hope that this information will create a base knowledge of the important issue around preemptive tobacco legislation. This webinar is for educational purposes only and should not be seen as leading to any legislative change effort in this next legislative session. So with that, I will go ahead and transfer back to Derek to get us rolling.
Thank you, Scott. So my name is Derek Harr, and I'm a staff attorney at ChangeLab Solutions, where I work on tobacco control and chronic disease prevention. I'll be providing a high-level overview on the different types of preemption and how they can help or hinder efforts to promote public health and health equity. I'd also like to take a moment to thank our co-presenters for joining us today, including Michael Baer from Grassroots Change, Michael Tynan from the Centers for Disease Control and Prevention, Mele Aramori from the Tacoma-Pierce County Health Department, Angela Gale, also from the Tacoma-Pierce County Health Department, Ben Yisrael from the Center for Multicultural Health, and lastly, but certainly not least, Kevin Schroth from the New York City Department of Health and Mental Hygiene. I also want to take a moment to thank Randy Frank and Asha Banks from the Centers for Disease Control and Prevention for their support on this webinar, as well as to thank Teresa Vogue and the Sonoma County, California Department of Public Health, who were planning to participate on this webinar but are unable to join us today as they continue to aid in the response to the devastating wildfires in Northern California. So with introductions out of the way, let's dive into the substance. In this Preemption 101 presentation, we'll be covering 3 things. First, we'll have a brief refresher on federal, state, and local authority, including where each level of government derives its authority. And I'll go ahead and apologize in advance if anyone has bad flashbacks to their high school civics class. Next, we'll talk about what preemption is, developing a shared understanding and vocabulary. And then finally, we'll talk about the different types of preemption and the circumstances under which each type can either help or hinder efforts to advance public health and health equity. When a government sets out to address a problem like increasing access to safe, affordable housing, or perhaps more relevant to this group, reducing access to tobacco products, it first must ask what it has the legal authority to do. And as we all know, government authority in the United States, including all authority related to public health, is divided between the federal, state, and local levels. The primary source of this authority is, of course, the U.S. Constitution. Under the Constitution Supremacy Clause, federal law takes precedent over lower-level laws. It states that it is the supreme law of the land. So if a state or local law conflicts with federal law, the federal law, the supreme law of the land, supersedes that lower-level law. The U.S. Constitution reserves police powers, those which form the basis of most public health policy, to states. And this reservation of authority to states is what we often refer to as a plenary power, meaning that states have nearly unlimited discretion in choosing how much, if any, of this power they will share with local governments. In other words, while the U.S. Constitution is the source of states' police powers, local governments must rely on the states themselves for this authority. And the degree to which local governments have autonomous powers varies greatly by the states. But even when local governments have general authority to act to protect public health, they might not be able to take particular actions or address specific issues. That's often due to preemption. At its core, preemption is when the law of a higher jurisdiction limits or even eliminates the power of a lower level of government to regulate a certain issue. This can take the form of the federal government invalidating a state or local law, or a state government invalidating a local law. Generally, a government can't do anything that conflicts with a higher level of government's law. But depending on the type of preemption, lower levels of government might be prevented from passing any laws on a certain issue, or they might be prevented from passing certain types of laws affecting that issue. So let's dive a little bit deeper into the different forms of preemption and what those different forms mean. Preemption can take many forms, and it's not an inherently partisan issue, nor is it universally negative. Whether preemption has a positive or negative effect really depends on how it's used and the type of preemption in question. In terms of how different types of preemption affect the ability of local governments to take certain action, there are three broad categories, each with their own costs and benefits. First, there's ceiling preemption. Ceiling preemption occurs when a higher level of government establishes regulations and prohibits lower levels of government from enacting additional requirements or restrictions. So this can be thought of as setting maximum standards. Next, there's floor preemption, which in many ways isn't really preemption at all. Instead, floor preemption is best understood as when a higher level of government just sets minimum standards that local governments can't go below, but they can still go beyond. Finally, there's vacuum or null preemption, and this is where a higher level of government doesn't establish any regulations of its own on a particular matter, but still prohibits local governments, whether that be state or local governments, from taking action to address a particular matter. So what are the costs and benefits of ceiling preemption? Ceiling preemption ensures that there are uniform rules applicable across the board, and this avoids what's often referred to as a patchwork regulatory scheme, where the rules differ depending on each community. And uniformity can make things more efficient. After all, if there's only one set of rules to follow, it's easier to make sure that you're complying with them. In a moment, we'll talk about an example where uniform standards and efficiencies benefit public health. But by setting maximum standards, you're also limiting flexibility. We all know that there are policies that may work in one community but not another community. And ceiling preemption prevents local governments from tailoring policies to meet the needs of their specific communities. And it can also stifle innovation because communities aren't able to test the effectiveness of different policies, and that makes it harder to establish an evidence base in order for those policies to diffuse to higher levels of government. So one example of ceiling preemption is airline safety regulations. Because we don't want pilots to have to worry about what standards and regulations might apply as they cross state lines in the air, it seems most logical and efficient to regulate airline safety at the federal level and not to allow state or local governments to enact different laws. And that's exactly what we do. Airline safety is regulated by the federal government, and states and localities are preempted from enacting laws in this area. In contrast, ceiling preemption doesn't make as much sense in the context of minimum wage laws. So to draw on a personal example, I currently live in Oakland, California, which I'm sure many of you know is one of the most expensive housing markets in the country. But I grew up in North Carolina, where the cost of living is much lower. So a minimum wage that might have been sufficient in North Carolina won't provide the same level of support in Oakland because of conditions unique to the particular communities. And this not only happens between different states, but also within individual states. So, for example, you could look at Seattle, which has a significantly higher cost of living than some of the more rural parts of Washington state. So in the case of minimum wage laws, any benefits to uniformity are really greatly outweighed by the inability to tailor policies that meet the needs of individual communities. Now, I'm going to break one of the cardinal rules of PowerPoint presentations by not giving you enough time to read this entire slide, but I wanted to give you an example of what ceiling preemption looked like. And this is a portion of Oregon's minimum wage law that includes a ceiling preemption provision. That's the bolded text. So Oregon sets a statewide minimum wage law that's higher than the federal minimum wage, but it prevents local governments from setting the minimum wage even higher. So this would prevent a city like Portland, where there's a higher cost of living, from making sure that its residents can afford that higher cost of living. As I mentioned earlier, the second type of preemption, floor preemption, isn't really preemption at all. Floor preemption simply sets minimum standards upon which local governments can build on. This approach has a great deal of advantages and relatively few drawbacks. For example, local control allows the flexibility to tailor policies to fit a community's needs. It can also foster innovation. States and local governments are often referred to the laboratories of democracy because they can test or refine policy ideas. So local control creates an environment that allows for the development of innovative policies by testing them on a smaller scale. And with innovative policies comes the opportunity to drive policy change more broadly and to encourage progress in areas that are unsettled because the science is still evolving or policymakers are still learning what works. Civil rights laws are one area where states may go beyond federal law, and in many cases where local governments can go beyond both state and federal law. For example, Title VII of the Federal Civil Rights Act of 1964 prohibits employment discrimination on, among other things, the basis of gender, including discrimination on the basis of pregnancy. But some states like California have gone further and required employers to provide greater pregnancy benefits than what is required by federal law. And you also see this play out, for example, in that sexual orientation and gender identity is not included explicitly in the federal law, but many states and local governments have enacted laws establishing those protections. Another example of floor preemption that's likely more relevant to all of you is the Federal Family Smoking Prevention and Tobacco Control Act. The law establishes a nationwide minimum legal sales age of 18 for all tobacco products, and this ensures baseline standards under which no state or local government can go below. They couldn't, for example, allow tobacco retailers to sell cigarettes to a 16-year-old. But the federal law also explicitly allows states and local governments to enact stricter requirements, and many have already done so through Tobacco 21 laws that raise the minimum legal sales age to 21. So you have states like California, Hawaii, Maine, New Jersey, and Oregon, as well as more than 260 cities that have taken that approach. And in June 2011, the Institute of Medicine, which has since been, as many of you are aware, renamed the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine, weighed in on the issue of preemption and the roles of various levels of government when it comes to public health. And as you can see from this slide, its report highlights floor preemption and says that governments, when they are regulating for public health or even just generally, they should make sure that they're doing, in most cases, floor preemption and setting minimum standards rather than ceiling preemption and setting maximum standards. And a number of public health organizations have taken similar positions, the American Lung Association, the American Heart Association, and the key driving home message is that while there's a role for higher levels of government to set minimum baseline standards that provide some sort of uniform protection for everyone, they should maintain the authority for local governments to respond to their individual needs. And then finally, there is vacuum or null preemption. And this occurs when legislators choose not to enact regulations in a particular field, but then actively forbid lower levels of government from doing so anyways. This typically occurs at the state level and therefore most often affects local government authority. Here you can see a map of the states highlighted in orange, and I'll give a shout out to Grassroots Change, who Michael Baer will be presenting from in just a few moments. This map and data comes from them. Highlighted in orange, you can see that as of February 2016, several states have laws preempting local policies related to food and nutrition. And depending on the state, local governments may be preempted from regulating menu labeling, nutrition information, portion sizes, and/or tobacco and/or toy giveaways in children's meals. While these states have laws that prohibit cities and counties from regulating any of the issues, they don't have any statewide standard, and thus you're really just creating a regulatory void. So this is an excerpt from one of Mississippi's statutes, and again, I will apologize for probably not giving you enough time to read all of it. But it expressly prohibits local governments from passing any laws that, for example, require the provision of food nutrition information, that prevent local governments from instituting licensing practices on the basis of the existence or non-existence of food-based health disparities, which really impacts local government's ability to address health equity, as well as restricting the sale, distribution, growing, raising, or serving of foods and non-alcoholic beverages that are approved for sale by the U.S. Department of Agriculture or other federal or state government agencies. And that last one is a really, really broad provision that essentially makes it impossible for local governments to regulate almost anything about food and nutrition and food systems. And this is true even though Mississippi, as a state, has not enacted any standards in these areas. The only thing that they've enacted is this prohibition on local control. And in this context, null preemption can have detrimental effects on public health efforts. Not only does it limit local efforts to address public health issues like chronic disease prevention, but it also creates a regulatory vacuum by not establishing a statewide standard. And as a result, it can prevent innovations and prevent important public health protections without adding to regulatory uniformity or without adding to regulatory efficiencies. So now that we've developed a shared understanding of what preemption is, the different types of preemption, and the benefits and drawbacks to the different types of preemption, I'd like to turn things over to Michael Baer from Grassroots Change.
Thank you, Derek. As Derek went into the general definitions of preemption, I want to give a slight caveat. When I say preemption, I'm going to mean only ceiling preemption in my presentation. So I wanted to go into some of the industry tactics we're seeing growing in frequency or newer tactics. One of these is blanket preemption, where the state passes a law in which no locality can set any standard higher than any state standard for any law across the board. Another one we're seeing growing in frequency is excise tax preemption across the board, or preempting local tax in a specific area, such as tobacco or sugar-sweetened beverages. Super preemption, which is only currently seen with guns, which is when a firearm preemption law is passed that has a clause written that allows for a third party or advocacy group to sue a local jurisdiction, city or town, for passing a law that is, or a local ordinance that is stronger than the state law. And this often creates a chilling effect because cities are, of course, scared to have litigation against them. And we're also seeing preemption with penalties, such as fiscal penalties. In Arizona, there is a mechanism that acts as a form of de facto preemption. This law provides that a state legislature can file a complaint with the state attorney general if a town, city, or county passes a law that violates state law or the Constitution of Arizona. If the attorney general agrees that the local law conflicts with the state law, the city or other locality has 30 days to rescind the law. If it fails to do so, the attorney general is to instruct the state treasurer to withhold state funds from the city. And I also wanted to state that we see preemption more likely to happen where we see wins pushed by local governments or grassroots movements, such as in recent wins in local sugar-sweetened beverage taxes. And one last thing is that the industry, they state things like the preemption makes the state more business-friendly and it's bad for local economies. But this is part of their communication strategy. As you can see here, there's a lot of quotes from the industry about why they like preemption, how it helps them. And the great point is that a lot of these messages can be debunked. You can debunk these common arguments around uniformity. And I'd like to point out that on our website we have a messaging toolkit that we developed with the American Heart Association, Voices for Healthy Kids, that has kind of best practices around countering the industry messaging around supporting preemption. So while preemption was formerly seen as a bargaining chip historically, it's now kind of a go-to standard for industries seeking to interfere with local policy setting. And as Derek said, we are also nonpartisan, but we do see a little partisanship happening at the legislature level, but not in the local communities. Any local community that's impacted by preemption, regardless of their overwhelming political lean, tends to dislike preemption, and there's a variety of reasons for that, of course. So some other industry tactics that we've seen is industry working directly in the community, creating fake grassroots movements, also known as AstroTurf. We recently saw this in Berkeley with the local soda tax campaign, where an individual was actually hired, moved to the community, registered to vote there, and then started organizing on the behest of the soda industry to try to stop the movement in its tracks. So these fake grassroots movements and industry groups don't represent small businesses as they state, but rather large multinational corporations. And so one great example that I'd like to bring up around community surveillance and marketing research is Project Scum. This is not an Andy Warhol reference, however, it stands for Subculture Urban Market. It was a plan proposed in 1995 by R.J. Reynolds Tobacco Company to sell cigarettes to members of the quote-unquote alternative lifestyle areas of San Francisco, in particular, a large number of gay people in the Castro and homeless people in the Tenderloin. One moment. By doing kind of the community assessments and marketing research, they realized that there were strong values for bodily autonomy and against government control in the LGBTQ community. So as local smoking bans were going on in bars, they were actually reaching out to the LGBT community with messaging around, is this what you want the government to do? More laws on your body telling you what you can do. So it just shows how very slick that they can be. Publicly, however, R.J. Reynolds made every effort to express support for their queer customers. Camel hosted a booth in the 2000 San Francisco Pride Parade and sponsored an after-party at a popular gay nightclub. And more recently, in 2011, Camel Snooze ad encouraged queers to take pride in your flavor. And so while there's a lot of industry tactics to circumvent local control and to promote their products, preemption really is the cherry on top of for them. So a little bit about the history of the smoke-free movement. It has been seen as the most effective public health grassroots movement to stop preemption in its tracks and repealing preemption. State preemption of tobacco was very broad across the 50 states, and throughout the movement they gradually repealed preemption of local authority in tobacco control and smoke-free. And also, preemption hurts local democracy. It creates a chilling effect on grassroots movements, kills public health innovation. Preemption, of course, makes setting higher standards more difficult, as the process for changing laws in state legislatures is onerous, makes it vulnerable to lobbyist and industry interference, and becomes politicized and can get lost in committee. And then some factors to consider when looking for preemption and ways to potentially counter it is to, of course, track and analyze bills that are produced in the legislature to see if they have preemption clauses or savings clauses. Educate the media through earned media and interviews to kind of discuss why the specific forms of preemption are bad and how they would affect local policy setting and local health. Building grassroots power has been seen as one of the most effective methods in countering preemption. Of course, decide beforehand what you're willing to compromise on. Sometimes the political process is so rotten partisan that you have to realize that you don't want to take preemption with very low standards because it will become so onerous to have those standards overturned later. And so I just wanted to mention a couple new frontiers that we're seeing that are related to tobacco and smoke-free, and that would be preemption in vaping and in marijuana laws, as we're seeing kind of spreading acceptance for legalization of recreational and medical marijuana across the country. And with that, I will turn it over to Michael Tynan.
Hi, this is Michael Tynan. I'm with the CDC's Office on Smoking and Health. Before I begin, I want to thank Washington's Department of Health and Seattle-King County for inviting me to be on the call today. I'm a public health analyst with the Office on Smoking and Health, and I work on issues related to smoke-free, point-of-sale, price, and preemption, and I'm based in Portland, Oregon. So I'm here today to talk about the evidence of what we know about preemption, not for or against any particular piece of legislation. Like Michael Baer before me, when I talk about preemption, I'm also talking about ceiling preemption. So what I'm going to do is I'm going to quickly walk through what CDC knows about the evidence, and then we'll highlight some national trends that we've reported on over time. So the strongest and most effective tobacco control policies have often been at the local level. They've originated at the local level. In fact, the 50th anniversary of the Surgeon General's report, which was released a few years ago, described how local smoke-free policies really served as a catalyst for transitioning social norms in this country around smoking and smoke-free. But because state preemption prohibits communities from enacting local laws, the results are that preemption prevents local innovation. Preemption also prevents communities from tailoring policies to fit local conditions and needs. And preemption prevents communities from even considering local policies or debating them, a process which we know itself educates residents about tobacco issues and can change public attitudes about tobacco use and social norms about tobacco use. We also know that the tobacco industry, as was put up by some quotes by Michael Baer before me, supports preemption. There are very revealing statements that we have from industry documents like, we, the tobacco industry, could never win at the local level. And they've said that their first priority has always been to preempt the field, at least at the state level, because the industry says health advocates can't compete with them on the state level. There's also a large body of evidence that CDC looks at that have made major scientific conclusions on the recommendations of preemption, which include numerous reports from the Surgeon General, reports from the Institute of Medicine, and reports from the Guide for Community Preventive Services, which is commonly called the Community Guide, which concluded that preemption is a major barrier to the implementation of effective tobacco control policies and programs. And the Community Guide says, and this is a quote, that the direct obstacle, the adoption of local clean indoor air ordinances and to local efforts to restrict youth access to tobacco use or to tobacco products from commercial sources. So the U.S. Department of Health and Human Services, which is the cabinet agency that CDC is a part of, establishes Healthy People objectives, which are sort of like our national public health agenda for each decade. And Healthy People has made numerous objectives related to tobacco control, and one of those is the recognition of the damaging effects of preemption and the importance of local tobacco control policies. The Healthy People 2020 objective, which is what the period that we're under right now, calls for the elimination of all state laws that preempt local tobacco control policies. So often when we have a Healthy People objective on a topic, CDC will report on these topics in the literature, or typically in MMWR, the Morbidity and Mortality Weekly Report. And so we released a report in 2011 that looked at preemption trends for the last decade. And we found that there were substantial changes around smoke-free preemption over the decade, with laws being repealed or invalidated by courts in Delaware, Illinois, Iowa, Louisiana, Mississippi, Nevada, New Jersey, Oregon, and South Carolina. And then North Carolina also partially repealed some preemption. So again, those states either had a state legislature repeal preemption or a court invalidated existing preemption on the books. And these changes were, as you can see from the chart on the right, which has a line that's going down and two lines that are flat, this was primarily around smoke-free preemption. We saw a decline in smoke-free preemption while preemption for advertising and youth access was flat over the period. And this wasn't particularly surprising or something that alarmed us at CDC because this was also the busiest period in U.S. history surrounding the adoption of new statewide smoke-free laws. So what we found is that as states were adopting such laws, smoke-free laws, that previously had preemption provisions, they were removing these provisions. And in some cases, including new language that expressly notes that local laws are allowed or even encouraged in the community around this topic. So the fact that there was no change in preemption laws for the other areas is much more of an indicator of the lack of new or strengthening laws in those areas than anything else. In our report, we also concluded that the decrease in the number of new state preemptive laws that were enacted and repeal of old laws during the past decade likely reflected the growing awareness on the part of local tobacco control programs and advocacy groups and public health partners that they now fully understood and acknowledged and expressed the negative public health effects of preemption that we know from the literature. So I'm really short on time and don't want to go into too much detail or take away from the Q&A that we might have with the other speakers. But what I do want to let you know is that there's other resources that we have available at CDC where we track state preemption laws in 4 areas. And so this map shows what the current status is for advertising preemption, smoke-free preemption, licensure, and youth access. There are also tables available to break down what each type of preemption exists in each state. And I think if there's good news out of this, it's that there are fewer states that have any preemption today than there was at the start of the last decade when we started to look at broad preemption for all tobacco control policies. There are actually only 2 states that have this broad preemption in all areas, and Washington, though, is one of those 2 states. The other is Michigan. So I think the quick conclusion is that preemption is a major barrier in protecting public health. Removing preemption is a key strategy by tobacco control programs across the country, and establishing preemption is a key strategy by the tobacco industry to stop tobacco control policies and innovative policies from being enacted. And that we've seen states have success in repealing preemption provisions as they strengthen tobacco control policies, including in southern states and tobacco growing states. So I think I'm going to hand it back over to Derek, and we're going to take some questions.
Thank you to both Michael Baer and Michael Tynan, for helpful and informative presentations. It doesn't look like we have any questions currently in the chat queue. Does anyone have any questions that they'd like to submit? If not, we could keep moving the webinar along, and of course there will be another opportunity to answer any questions at the end of the webinar. So I'll give like 30 seconds if you want to get a question in, and then we will move on with the remaining presentations. All right, it doesn't seem like anyone is going to be submitting questions. Everyone should not be shy. We promise we don't bite too much, but please submit questions. We'll have, there we did get one question. So the question is there a relationship between smoking rates and status of preemption in states? And I think I'll give that one to you, Michael Tynan, if you have any insights on that.
Well, I mean, I think it's a little more complicated than that because we have many states that have preemption are southern states in many cases that have smoke-free preemption or preemption in other areas. So it's much more complicated. I think there's so many factors that come into play. I don't know that we've seen a relationship necessarily directly. I think the relationship is a lack of strong tobacco control policies, which because of a lack of strong tobacco control policies can lead to higher smoking rates. But I'm not sure that analysis is done.
Yes, great points. And I will say that is the lack of information on there is a good future area for study, plugging some of our other work with the legal epidemiology model of looking at the relationship between laws and health outcomes. So that's certainly a great question and something that's worth following up with. It doesn't look like there are any other questions, so I will turn things over to Angela Gale and B.A. Aramori from the Tacoma-Pierce County Health Department.
This is Angela Gale, and I'm here with me, Aramori. We're talking about the local impacts of preemption that occur here in Pierce County. So I'm going to start talking about kind of the historical context of Tacoma-Pierce County Health Department. We have traditionally taken a bold stance on tobacco issues and tried to provide a leadership role in the state that has helped build momentum for many years to help elevate significant tobacco prevention issues and regulations from the local level to the state level. For just more background, Pierce County has had some sort of iteration of a vapor product ordinance since 2011. For some context on that, in 2012 was when the WHO Framework Convention on Tobacco Control started collecting data for e-cigarettes and vapor products, electronic nicotine delivery systems. This was the first time that they actually sent out an optional module with their data collection for countries at the international level. So Pierce County has been very forward-thinking with their e-cigarette and vapor product regulations. So when the state vapor product law had not really been passed in 2014, Pierce County decided to start working on their own regulations, and this involved a lot of community engagement. And it was very rigorous, and it went from 2014 through 2015. So this included Board of Health members, public testimony from vapor product shop owners, community partners, schools, physicians, vapor industry representatives, other local health jurisdictions. Community events were held. They went to fairs. The local or the Liquor Cannabis Board was consulted, and on and on. So this kind of community engagement built a lot of trust within the community. It created and strengthened a lot of relationships with community partners, and these regulations were tailored to meet the needs of our diverse community here in Pierce County. An example of that is that throughout the stakeholder input, it informed the final policy of our Chapter 9 Environmental Health Code to include both protections for secondhand exposure to vapor and also met the sampling needs that the retailer businesses requested. So there were a lot of benefits to these policies. There's also a lot of benefits to the state law. RCW 70.345 that was passed in 2016 went into effect, and we had a state vapor product law that had really positive impacts. The retailer licensing that did not allow for sale to people under 18 from purchasing, it also helped regulate online sales, and the child-proof labeling and packaging requirements were very stringent and were very positive. So aside from this law, there are also other strategic laws that really need to be regulated and passed at a state level. An example of this that's already been mentioned is Tobacco 21. We also have a very strong smoking in public places law that is important to be consistent across the state. So some implications of preemption that have affected us here in Pierce County was revisions and community changes that affected our Chapter 9 Environmental Health Code. So it's kind of a double-edged sword. So building this community momentum led to this state vapor product law. but passing local regulations resulted in this state law. There was some significant preemption and some kind of ambiguous language in this vapor product law. And we all know that no legislation is perfect. This did have some impact on our community relationships and our ability to build community momentum for future tobacco regulations. And working with community members on Tobacco 21 efforts that did take place. And these relationships we built with our community partners were affected. So the key takeaway is that this local control with policy affected things that we weren't able to work on, such as retailer density and zoning, that really would have helped us address things such as health equity and health disparities that exist within our diverse county, and youth access. Our SINAR rates are higher than the state average, and we would have been able to address that at the local level and tailored that to our needs. We did also have to roll back and revise all of the work that had been done with retailer licensing at the local level, including returning retailer licensing fees. Other things that have occurred is questions that we get from the community like, they have a vape lounge, why can't I have a cigar lounge? And we get a lot of pushback on that. There's also some inconsistencies between smoking in public places and vaping in public places, and we get a lot of questions from schools and school districts that have some confusion regarding smoking on school grounds and vaping with school grounds and issues with that. So those are just some examples of some issues we deal with because of that. So kind of what now? What do we do now in our community with our state vapor product law is we do educate our community about vapor products and local and state regulations. And our goal is always youth protection and to protect the public from secondhand smoke and vapor product exposure. And we continue to work towards these goals with our community partners. Our other goal is to work together across counties and accountable community of health regions to collaborate and communicate and continue to educate about our experiences with vapor products and smoking in public places. And we'd like to work within the parameters of the preemption to really create consistency within these parameters and how we communicate this with retailers and smoking in public places and vaping in public places so that we can work towards consistency and really find a way to strengthen our local control within what the parameters of this. We would like people to learn from our process and work to problem solve these issues and really make the best of these strong SIP laws that we have and work towards some stronger good legislation that we see coming, like Tobacco 21, and really work to build trust with our community and move forward with some strong state laws. Thank you so much, and if there are any questions in the chat box, we're happy to answer that.
Thank you. So please feel free to submit questions, and we will get to them in the next question and answer session at the end of the webinar. I'd like to turn things over now to Ben Israel from the Center for Multicultural Health.
How's everyone doing? Just before I get started, I'm going to need some help turning the slides as I mentioned before because I'm still having a few technical difficulties.
Yep, I got you. Just say next slide and I will move it.
Cool. Let's go ahead and go to the next slide. So the purpose of our presentation today is to talk about preemption from a health equity perspective, and I'm here today representing Center for Multicultural Health, as well as a work group in Healthy King County Coalition called Tobacco, Marijuana, and Other Drugs. And all the work is nonpartisan, but we come together to do research and build community awareness and to reduce the impact of tobacco, marijuana, and associated drugs in our communities. Next slide. So before I go forward talking specifically about preemption, I want to talk about just some of the trends in Washington and just kind of give a history about why health equity is important. If we look at recent history in the state of Washington and look back at the Washington Tobacco Facts 2015 report, we can see that we had a major investment by the state of Washington in tobacco prevention control, and we also had major reductions in smoking. In fact, at one point, cigarette use dropped by 23% in Washington state, outpacing national reductions in smoking. So we do know that there has been a lot of positive progress made in Washington reducing smoking. However, there are still many issues that minority groups, specifically racial minority groups and the LGBTQ community are still facing. Next slide. So one of the things that happened after we saw this trend of success in a reduction in smoking and cigarette use is we also saw a drastic reduction in funds and prevention programs. In fact, in recent years, Washington has been one of the many states that have funded prevention programs at a level that's drastically below what was recommended by the Center for Disease Control. For example, the Center for Disease Control recommended $63 million a year for cessation and education programs in 2016. And Washington last year, there were about $2 million allocated statewide for those prevention programs. Next slide. So when we talk about tobacco-related disparities, there are many. Again, as we know, there have been a great reduction in cigarette use. However, we have seen some rises, upticks in use by youth in smokeless tobacco, as well as vaping. Say, for example, 10th graders' use of cigarettes and smokeless tobacco has gone up from 4.6 to 18% in recent years. We also, again, note that there are major disparities amongst racial minorities and members of the LGBTQ community. Some examples, when we look at racial groups, according to 2015 information we have, the smoking rate among Anglo or white citizens in Washington was 16.6%, whereas American Indian rates were 36.6%. The rate among Pacific Islanders was 24.4%, and individuals labeled as multiracial had a smoking rate of 25.6%. And then when we look at sexual orientation or identity, rates among heterosexuals, 5.7 compared to, we're looking at adults now, LGBTQ members, 9.9%. So we know that there are major disparities, and we know as Michael Baer noted, that a lot of these things are targeted. Michael Baer spoke a little bit about some of the tactics that were used against members of the LGBTQ community. We also know that this has happened in immigrant communities, the African American community as well, funding for major social events, educational events, sporting events. So we have members of these marginalized groups being targeted, not just from the mainstream types of advertisement, but also specifically targeted towards them. So now, next slide, I want to talk about health equity and then put that in the frame of preemption and what does health equity mean when it comes to preemption. So researcher named Osterly, 2002, argues that there are at least 4 equity objectives that can be identified. When we look at health equity should create guaranteed minimum standards. It should support living standards. It should lead to the reduction of inequality. And it should lead to the promotion of social integration. Next slide. So then the question is, when it comes to preemption, what should policies do? And specifically, what should preemption, how does it relate basically to health equity? Well, one, when considering whether a policy positively impacts the health of individuals in a marginalized group, one should confirm that the policy meets at least one of the 4 objectives mentioned by Osterly. A health equity policy should aim at benefiting the health of marginalized people by doing one of the 4 things: seeking to establish guaranteed minimum standards, supporting the maintenance and expansion of living standards, seeking to reduce inequality between the group and the broader population, promoting social integration, and engaging in educational activities that reduce stigma associated with the disease or disability. A second factor that health policy advocates should consider is if there are adequate funds or resources to successfully implement the policy or program. Underfunding has often been a tactic used by policymakers using to obstruct equity-focused policy. Point 3, another factor that health policy advocates should consider is whether a policy can be implemented without placing an undue burden on the group or individual seeking benefits. 4, when seeking to prioritize between multiple policies that fit a health equity framework, advocates should consider the range of impact. And finally, we should look at the health equity impact of all policies, meaning a policy may not be framed as a health policy, but when we really look at all policies, they are going to have some type of health impact. Next slide. So building off of some of the standards we just talked about when it comes to health equity and what we should be looking for, one of the points I want to go back to is the point that Osterly made that a health equity policy should not cause any undue burden on a marginalized or target group. And we definitely see that by taking away local control to innovate, and preemption can really have an undue burden on target or marginalized communities and make policy change more difficult. From a health equity perspective, preemption makes it more difficult not only to implement more innovative policies, but from a health equity policy perspective, it also affects funding, because funding that could be used for prevention or treatment has to be used by grassroots organizations for advocacy. So if we're really going to look at preemption, it does make it difficult for those racial minority groups as well as gender and LGBTQ communities to implement the types of policies that can specifically help their communities. And with that, I guess we'll move on to Kevin.
Hi, this is Kevin. Thank you very much. Just 1 second as I get my slides ready. Okay, so when I was asked to be a presenter on this panel, one of the underlying ideas was that New York City is this jurisdiction that hasn't had to wrestle with preemption quite the same way that some other areas, like everybody in Washington State has been, and Michigan has been dealing with it. So first, I just want to dispel a little bit of a misperception. We are not the land preemption forgot. We do have preemption, but that said, we do have some advantages. So some of the preemption that we've faced has been federal. Everybody has federal preemption. We also have some state preemption issues that I'll get into. On a federal level, though, just a tough reminder about that came in 2009 when New York City required point-of-sale warning signs to be posted in retail tobacco outlets, and we lost a lawsuit on that, where the Second Circuit Court of Appeals held that the rule essentially interfered with the advertising and promotion of cigarettes, which was protected under a federal law. So, but we put that in the rearview mirror and kept moving. Here's a quick slide that just shows some of the progress that New York City has made in tobacco control, and it shows that essentially since looking all the way in the upper left corner of the slide, you can see a representation of the time period before Mayor Bloomberg got started in what I think of as our modern tobacco control movement for New York City. During roughly 10 years before that, there was no movement, no significant movement in smoking rates, and they were stuck at around 21 or 22%. After New York City started working on that, we started making progress through implementing various laws and other strategies, tax increases, and we've seen that number go down to 13.1% for adults. And I'm going to go through some of the strategies that we employed along the way. But the green arrows give you a picture of what we were doing at certain periods of time and help show the associations between those interventions and the reductions that we were experiencing. First, though, I just wanted to make a reference to an example of, or a few examples of where New York City actually passed laws and then New York State subsequently passed their own versions of the same laws. So not only were we not preempted by New York State, but we were helping to spur New York State forward. In 2002, we passed our modern version of our Smoke-Free Air Act. New York State followed about a year after. 2009, we amended it to prohibit smoking close to hospital entrances and exits and on hospital grounds. The state followed suit about 4 years later. We passed a law that made parks and beaches smoke-free. The state passed a regulation that had to go through some legal challenges but was ultimately upheld shortly after us. And just the other day, Governor Cuomo signed a New York State law extending the scope of the State Clean Indoor Air Act to cover electronic cigarettes, which New York City had done several years earlier. Two other laws that we have passed in New York City and that the state has made an effort to pass but has not done so yet successfully relate to restricting the sale of flavored other tobacco products and restricting the use of discounts and other price reduction mechanisms for tobacco products. So now I'm just going to do a quick list of tobacco control laws that were passed during the Mayor Bloomberg era. He was the mayor for 3 terms, about 12 years, and this is a great picture that was on, I forget if it was the New York Daily News or the New York Post, but it's the iconic picture of Mayor Bloomberg as the nanny, which was done around the time that we passed a rule related to the size of sugary beverages. In any event, we have a number of Smoke-Free Air Act, the law, and a number of amendments related to it. Our flavored law, STE, is an acronym for Sensible Tobacco Enforcement, which was really a collection of ideas or laws that targeted the problem of inexpensive tobacco products. So, and this followed after New York City already had very progressive and very high cigarette taxes, but as we continued to study the tobacco market over the years, we found that people were coming up with strategies to try to avoid those high taxes by finding less expensive products. So essentially, this was a law that was designed to kind of plug the holes in the dam and cut off these avenues through which inexpensive tobacco products were available. And then also at the end of the Bloomberg era, we passed our Tobacco 21 law, and we recently updated that. I'll get to that in a second. So just in the past few months, New York City has passed 10 different tobacco laws. These range from establishing a comprehensive set of minimum prices for various different types of tobacco products, and a tax on other tobacco products, i.e. non-cigarette tobacco products, a number of laws that restrict access to tobacco by taking tobacco products out of pharmacies and reducing the number of establishments that have licenses for tobacco and also for e-cigarettes. We're creating an e-cigarette license that's separate from the tobacco license for the first time. Before we created this license, and it hasn't gone into effect yet, so we still don't know where e-cigarettes are being sold, especially if they're sold from somebody who does not have the tobacco license. The tobacco license in the process was renamed from a cigarette license to a tobacco license, so we make sure that people that are not selling cigarettes but perhaps are selling cigars or smokeless products are going to be regulated. And there's a few other laws that I'll get to, but in the right-hand column, we reference laws that we passed to regulate hookah bars for the first time in New York City. We're requiring a permit. We're requiring hookah bars to post a warning inside where hookah is smoked and at the door, and we're extending our Tobacco 21 law to cover various other products, including products that don't contain tobacco but involve smoking like tobacco, and that could include a non-tobacco shisha. As you may know, shisha comes in different, shisha is the substance that's typically smoked in a hookah pipe, and it comes in different varieties, and although tobacco-containing shisha tends to be the most popular form, non-tobacco shisha is also a present part of the market. I like to compare it to decaf coffee. It's not as popular, it's not as easy to find, but it's out there, and it's not that hard to find. Now, the hookah bars in New York City were not allowed to serve tobacco-containing shisha because then they would be covered by the smoke-free air law. So a lot of them we found were serving the non-tobacco, or claimed to be serving the non-tobacco version, when in fact that's not what they were serving. They were frequently serving tobacco. So this law helps to counter that. So I'm going to back up again and go through some of the laws that I just mentioned. First, I'll go back to New York City's flavored restriction. This was passed in 2009. So this was the first jurisdiction in the U.S. after the Tobacco Control Act was passed in June of 2009 to restrict the sale of flavored tobacco products. New York City originally was thinking about flavored cigarettes as well, but when it became clear that the Tobacco Control Act was going to cover that, the people working on this law went back to the drawing board and decided if it was still worth the effort, and they decided that it was, but that the law could just pick up where the Tobacco Control Act left off in terms of flavored sales and cover non-cigarette tobacco products. Now, partly because it was done back at that time, it has the same exemption that the Tobacco Control Act has had for menthol and continues to have for menthol. The Tobacco Control Act called for a study on menthol, which came out, actually two studies came out around 2012 and 2013. I may have my years a little bit off, but in that general time frame. And we didn't have the benefit of those studies back when we were doing what we were doing. So our law restricts the sale. It doesn't ban the sale of flavored tobacco products because there's a category of stores that are allowed to sell tobacco products under New York City's law, and they happen to be 8 tobacco bars. In a city of 8 million people, there are 8 tobacco bars. This is a separate category, a pre-existing category that dates back to the 2002 Smoke-Free Air Act, and they tend to be high-end places that sell expensive cigars and nice scotches and things like that. So very few of these places, perhaps none of them, actually sell flavored tobacco products. But by providing an exemption to that category of stores, when we were subsequently sued, we were able to say that our law was not a total ban on the sale of flavored products, but a restriction on flavored products. In terms of what products are flavored, it applies to products with a characterizing flavor, and that includes, but is not limited to, products that are fruits, desserts, alcohols, or spices. In recent years, we've seen that a lot of tobacco products are now sold in flavors that are not initially apparent by the name of the product. So products like that used to be grape cigars were subsequently renamed, and with the same packaging and the same color schemes and font and everything, they were renamed as purple. So now it seems pretty clear that they're still flavored, but that presents a problem when you're trying to have an inspection plan that relies on consistent, clear instructions that can be implemented even-handedly by dozens of inspectors who are out in the field. So we're still working on this one, but we have found that the law was generally pretty successful, and I have a few slides on that. Before I do that, in the lawsuit, when we were sued, it was a preemption lawsuit, and the tobacco industry essentially argued that we were creating a manufacturing specification in disguise, and that's something that the Tobacco Control Act clearly says is something that belongs to the federal government. They essentially cover the field or preempt the field with respect to manufacturing specifications. Our argument was that our law says nothing about manufacturing specifications. All it applies to is the sale of the product. So it is looking at the product as it's finally put on the shelves without getting into what process got the product from point A to the ultimate, from the manufacturer or from the tobacco field to the shelf. And the court sided with us and said that it was within our authority to come up with a restriction on a niche product. That was one of the phrases of the Second Circuit used. And it pointed out also, I should note, that our law was not a ban, it was a restriction. So the fact that we had those 8 exempted tobacco bars was something that the court was sensitive to. So moving on to impact. This slide shows declines in the sales of flavored cigarettes, which was covered by the federal law, not ours, but it's an interesting benchmark. And the dotted line, this is in the upper left graph. The dotted line there shows when the FDA when the Tobacco Control Act went into effect. The upper right slide shows what happened to flavored cigar sales, and you can see there's a sharp decline and then a leveling off at a much lower level. Interestingly, the sharp decline was timed close to when the law passed. Because of the lawsuit, it was not implemented for a little while, and that's where that dotted line shows up. But sales practices had already responded to the law before enforcement began. And for the sales of flavored smokeless tobacco, there was a similar drop-off. In fact, it was even more dramatic. Our data shows that there was a 91% drop-off for flavored cigars and 100% drop for flavored smokeless tobacco. Now, I should note that these numbers are probably a little bit more favorable than the reality, and that's because this was pulled from sales data at large retail stores, and that was defined as stores that had business of over $2 million per year, roughly. So that excludes a number of the smaller retailers, the New York City bodegas. And we know that the non-compliance among the bodegas is higher than it probably is for some of these large retail stores. So nevertheless, these slides do show, based on the available data, that our law was having an impact. Another really interesting thing about this, the data related to our flavored law, was that it even had an impact on the sale of menthol cigars. And as I said before, menthol was exempted from our law, but there's this dramatic decline in menthol cigars, and we don't have a good explanation for this other than retailers may not have understood the law that thoroughly, and they may have thought that it applied to menthol even when it didn't. Moving on to the sensible tobacco enforcement law. As I mentioned, we were looking to kind of fill a couple cracks in the wall here, and so we started searching for sources of inexpensive tobacco that people were turning to try to avoid the high prices that New York City has primarily because of our high cigarette taxes. So we found that they were turning to discounted tobacco products that come through industry-sponsored coupons and other price incentives. They were turning to little cigars and other cigarillos that are similar to cigarettes, and these are generally not fat premium cigars. These are manufactured cigars that are small and often have filters and are frequently smoked, inhaled, like cigarettes, so unlike a more expensive large cigar where people are puffing rather than inhaling. So they're designed that way. They're designed to be very similar to cigarettes, partly because they're taxed at lower rates and regulated less rigorously. Another gap that we identified was the sale of untaxed cigarettes, and we know very well that there's an illicit market, and New York City is probably the epicenter of that illicit market. Because we have almost 1 million smokers in one metropolitan area, and we have and we're about a 5-hour drive from Northern Virginia. So, and that's a source of cigarettes that cost somewhere in the $5 range versus $11 or more. So the sensible tobacco law had a restriction on the sale of tobacco products for discounts. It set minimum prices for cigarettes of $10.50 and for little cigars of $10.50, which was a very significant price increase for little cigars. We required inexpensive cigars to be sold in packs of 4, and then we created some new penalties related to people who are involved in tax evasion. So all of these rules or requirements were passed as one comprehensive package to try to tackle that complex problem. Again, we were sued, and we were sued on there was a First Amendment argument. Essentially, the industry argued that our law restricted their ability to communicate to their customers that they were getting a bargain. And we won on that part of the argument. The court held that it really did not implicate speech. It was a restriction on a transaction, and what we were doing was regulating how the transaction could take place. Then there were 2 preemption arguments, first on a federal level and then on a state level. On the federal level, the industry again looked to the FCLA, the Federal Cigarette Labeling and Advertising Act, saying that we were restricting, it was a requirement related to smoking and health risks that had an effect on advertising and promotion of cigarettes. But through the Tobacco Control Act, we were able to argue that it fit within a new exception that applied to the manner of such a regulation or of advertising or promotion. And the court agreed with us and held that it did fit within the manner exception. The state preemption lawsuit, I think, is a little bit more interesting for purposes of our conversation. There was an old law from 1992 that prohibited the distribution of free tobacco products and coupons redeemable for free tobacco products. Now, the court focused on this argument more than we expected it to, and we had to submit a whole set of briefs after the initial set of briefs and walk the court through the legislative history. And when we did, it became clear that when this law was passed, there was a specific practice that was taking place that took place on street corners, it took place at concerts. Tobacco industry had marketing people that would go and hand out free tobacco products. And when they started to get restrictions imposed upon them for that conduct, they started to hand out coupons that were redeemable for those tobacco products. Or they started to hand out coupons that said you could get a tobacco product for a minimal price, like a penny. So the state law that addressed that was really targeting a specific type of practice that was taking place back in the early 90s and the 80s. And it really was not contemplating what we were looking at, a number of years later, where we saw the industry providing these coupons that were in the nature of $1 off, $1.50 off, or buy one, get one for a discount. So once the court understood the context and the different legislative goals at different periods of time, it found that preemption was not appropriate given the law that we had passed. I'm going to skip through that slide that I just discussed. Tobacco 21 was another law that we passed at the end of the Bloomberg era. It's pretty straightforward. A lot of jurisdictions are looking at it, which I think is great. I think it holds a lot of promise. But I'll just note that just in the past few months, we updated our Tobacco 21 law to make sure that it applies to non-tobacco shisha. It also applies to herbal cigarettes, pipes, rolling paper, and other smoking paraphernalia. This helps kind of clean up a little bit of a confusing area that was left behind after Tobacco 21 first passed here, where retailers didn't necessarily know or feel comfortable knowing that they were complying with the law, because if you've ever handled packages of shisha, it's not 100% clear which ones have tobacco or not, and you really have to read them carefully. And now we have a blanket application of this law to all smoking-related products. Hasn't gone into effect yet, but we're on our way. In terms of impact from our Tobacco 21 law and our discount ban and other parts of sensible tobacco enforcement, we were the first large jurisdiction to pass a Tobacco 21 law. We did it at the same time as our STE law, so it's hard to parse out the impact of one law versus the other. And our Tobacco 21, I'll just say from the outset, is a law that's designed and likely to have a long-term impact as people who grow up with it age up. Nobody really expects this to have an immediate dramatic impact. But the initial analysis shows that we've seen progress in various areas where we have measurable data that are covered by these two laws. So cigar pack sizes increased after STE went into effect. Cigar prices increased. We saw decreases in youth cigarette smoking from about 8.5% to 5.8%. We saw a similar decrease in youth cigar smoking, which went from, I think, 7.9% or 8.1% to 5.7%. We saw decreases in youth combustible use when you combine the two, decreases in smokeless use, decreases in ever trying cigarettes, and decreases in initiation over the last 12 months. So again, while the results are still coming in, and the initial signs are that we're headed in the right direction. Our 2017 tobacco laws focus a little bit more on other tobacco products. This is where we have minimum prices for a wide range of tobacco products. We have our retail density law. Here's a slide on retail density. This is based on research showing that easy access to tobacco makes it harder for people to quit, and the visibility of tobacco in retail outlets has an impact on youth who frequent convenience stores by making them more likely to try. One interesting thing about our pharmacy ban was that we noticed that pharmacies in New York City are not distributed proportionally citywide. And if we had just done a pharmacy ban, we would have had a greater impact in Manhattan, and most specifically business districts within Manhattan, and less of an impact in outer boroughs. So that was just one part of our plan, and we wanted to have a broader retail reduction plan that's designed to cut the number of retailers in New York City in half over a number of years through attrition. Here's a quick visual of how that could play out in two specific neighborhoods, the Upper East Side and Harlem. And again, this is a nice visual because it shows how in the Upper East Side, which is a more affluent neighborhood, there's a lot more pharmacies than there are in Harlem. But the populations in both areas are similar, and the density of tobacco outlets is similar. It's just a different makeup of those tobacco outlets. So by just taking out pharmacies, you make progress in the Upper East Side, but not so much in Harlem. But through a 50% reduction over time, you're going to see a reduction in density in both locations.
Thank you, Kevin. So I know, sorry to cut you off so abruptly, but I want to make sure that we leave time for questions to be answering. And the slide decks, I believe, will be available after the presentation. So they'll be people will certainly be able to check out the other slides on, for example, the e-cigarette licensing cap, the OTP price increases, the minimum price laws, and the housing disclosure laws. So again, sorry to cut you off, but I want to leave at least a few minutes for questions. And so I think we had a few questions. The first being, the question was, I appreciate the why of overturning preemption, but the how seems to be the biggest challenge. And the person submitting the question was wondering if we were able to speak to the practical aspects of trying to overturn preemption or give resources on strategies. And he noted that the particular challenges in Washington State are that they have tried and failed to overturn preemption in the past. And so I want to throw that question both to Michael Tynan to give a little bit of a historical context on where preemption has been repealed, and then to Michael Baer as well to talk a little bit more about the strategy part.
Yeah, so this is Michael Tynan. I think, I listed several states, and we talk about it in that MMWR that we published, that have had a successful history of repealing smoke-free preemption. The history on this is that it's typically a part of a larger legislative package. So, as the state is adopting a comprehensive smoke-free law, they typically repeal preemption at the time. Now, as to the strategy and why that's been successful or unsuccessful in some states, or how Washington State is different, I can't speak to that strategy. I think it would be interesting maybe to hear from some folks, maybe from state health departments or even advocacy organizations in those states where they've successfully repealed preemption, to see how they were able to have that discussion. Keep in mind, we're not talking about this only happening in a certain type of red state or blue state, right? We've got tobacco growing states like North Carolina, southern states, Mississippi, South Carolina that are not necessarily the leaders in tobacco prevention, who've had success in repealing preemption laws. And so it'd be interesting to hear that. I don't know the answer if Michael wants to talk further. regarding the strategy, though.
Yeah, hi, this is Michael Baer. So the one thing I wanted to note was that the Americans for Non-Smokers' Rights, whose website I highly encourage everyone to go visit, has a host of case studies and other items that show really how they mobilized communities and grassroots movements to urge legislators to overturn tobacco and smoke-free preemption by bringing together a disparate group of folks from the religious centers to people employed in, let's say, casinos where smoking was carved out of smoke-free preemption. So they have a lot of great case studies that really explain how movements were built, how they collaborated, and how they really succeeded through media campaigns, door-to-door campaigns, and a variety of other tactics.
Thank you. And if that's not a full answer for some people, this is a topic that is obviously very important and that we can come back to and discuss and follow up to today's webinar. I think we have one more question that's directed towards Kevin, and that's whether New York City has seen any results specific to health disparities, kind of that health equity lens following the implementation of these various policies.
I hate to say it, but not really. If you look at the progress that we've made among different races, ethnic groups, etc., we've made progress with just about everybody, and it tends to follow similar trend lines. We actually have a higher smoking rate for our white population than Black and Latino and Asian. There are some areas where we have not had a tremendous impact, and people with mental illnesses, for example, have been hard to reach. Certain subgroups of populations, like Asian male, especially those that are born abroad, have extremely high smoking rates, and we try to be strategic and think about ways to reach certain populations, but we haven't had this broad shift where we've seen health disparities corrected, and in fact, as I noted, some of the areas that people typically think of as minorities have lower smoking rates than the white population.
Thank you. It's really interesting because that kind of contrasts with a lot of the rest of the country where smoking rates among whites is significantly lower. So it'd be interesting to look into potentially why that's the case in New York City. Well, it looks like we are at 11 o'clock. I want to once again thank all of our presenters, our coordinators, Francis and Scott, as well as the Centers for Disease Control and Prevention for providing their support on the webinar. This is kind of just the first stage of next steps in Washington State, and was intended to kind of make sure that everyone's on the same page about what preemption is and why it's important to think about. And so with that, I will let Francis and Scott say any last words if they have any, and we can end the webinar. And I do believe that the slides will be available after the webinar, so if you missed anything or want to reference back to it, you'll be able to do so. So Francis or Scott, anything to add before we conclude?
No last words from Francis other than to thank the webinar presenters. Thank you so much for your presentations, and to thank everyone who joined the webinar today also. And we'll certainly be in touch with any next steps. Thank you.